Good morning, my name is Suzanne Barber. I'm one of the eHealth practitioners and I'm here to give you a talk this morning about the new module in EOBS, which is going to be the sepsis. The reason the Trust is bringing this new module in is that every year 52,000 people die of sepsis. We're not saying that every one of those deaths could be avoidable, but certainly a large proportion could be if we had early recognition and quicker treatment. We're now moving on to the NICE guidelines, and if you want to have a look at the NICE guidelines, you can go onto the Sepsis Recognition, Diagnosis and Early Management page in NICE, and you can find all the information and all the facts that we're using here today are from that. Okay, so we're going to start with an example. We've got a gentleman, he's called Mr. Jones and he's 68 years old. He's had a chest infection for 4 days. He's been on all antibiotics, but despite being on these, he's deteriorating. He's now confused, disorientated, he has a pulse of 135 and a rest rate of 28. We record his observations on EOBS, as we have done previously. It follows the NEWS guidelines, starting with the rest rate, going down finally to skin confusion. In the background, the sepsis module is now screening for any of these trigger points that you see on the right hand side. Looking at a rest rate of more than 25, inspired O2 requirements of greater than 8 litres or 40%, a systolic of less than 90, a heart rate of 130 beats per minute or more, new confusion or reduced orientation alertness to voice, pain or unresponsive, a reduced urine output or no urine output, and skin changes, non-blanching rash, mottled, ashen, cyanotic. Firstly, we're going to look at a trigger, an alert that comes to all the registered nurses on the ward, and what they would do if they thought that patient didn't have sepsis. And that could be because the patient is known to have a cardiac issue and therefore has a high heart rate, or any other reason that you've already got acknowledged. So when those OBS are admitted, every RM would then get an alert, and it says up there to think sepsis. Could this be sepsis? This patient has met the criteria, that means they have a high risk of red sepsis. Do you think they could have an infection? And that's asking all the registered nurses to stop and think and look at this patient. They then select no alternative diagnosis in this example because they believe this patient does not have sepsis. That will then change the handover field to sepsis screening, sepsis unlikely, and they acknowledge that alert. In our example of our patients that we were discussing before with our chest infection, they would suspect that this patient had sepsis. Therefore, they would choose likely infection, source known. If they were not sure of the source of the sepsis, they would select likely infection, source unknown. Both of these options would then take the patient down the same pathway. It creates a yellow sepsis flag in your flag section on your NerveCentre, and then in the handover section it will come up with sepsis screening, sepsis suspected. This action then creates a task for all nurses signed into that patient. It asks them to look at the patient and to start thinking about the patient's requirement, and takes them through what we traditionally call our Sepsis 6 or buffalo. It asks you to look at your patient and maintain their saturations of 94 to 98%, applying oxygen if required. This is 88 to 92% if they are CO2 retention on. They take 2 sets of blood cultures, FBCs, Usinase, CRP and clotting. The patient needs a lactate. You need to ensure your patient has good IV access, and broad spectrum antibiotics will be started without delay. If the patient has a systolic BP of less than 90 milligrams of mercury or a lactate of greater than 2, then they will need a 500 ml fluid bolus. It then encourages the nurse to consider a senior review and discuss with the consultant or consider CPOT. Not every nurse will be able to carry out all those actions at any one time. So they would do what they were able and competent to do, add what they have done in the comments section, labelled there with a 3, and then select started. That then indicates that this patient has begun their sepsis pathway and the treatment has commenced. When someone's been able to complete all of those actions, whoever does that will go into the task section, document in the comments what they have done, that is now completed, and then choose your completed tag there by the 5. Without delay, a doctor also needs to be summoned. This can be done with the messaging functionality of your iPod. However, you do need to make sure a doctor has been logged in and will therefore receive that message. You can also use your telephone to either phone them or page them, but it is important that a doctor is told immediately. Once the junior doctor has reviewed the patient and they have selected that treatment is commenced, that sepsis flag now turns red, and in the handover section it now changes to sepsis treatment commenced. That then changes after treatment has been completed, when the doctor changes it on their device, and the sepsis treatment completed will then appear in your notes, and that sepsis tag disappears. If you enter the wrong observations to the wrong patient, you can strike these out as you have done previously. However, this does not strike out that sepsis flag. The only way to change that is to go into your handover section and manually change it to not screen for sepsis in your sepsis screening section. This is the only time where you should alter the handover field. If a nurse screens a patient and suspects that sepsis is present, then the junior doctor will then get an alert. They need to accept that task, and that then creates their tasks for them to complete. The doctor will then have a choice himself or herself to either choose sepsis is likely, and this then changes that sepsis handover field to red. They can add comments via text or dictation to update the progress and treatment of the patient. Once the treatment is completed, they then choose sepsis treatment completed. If they suspect it is not sepsis, then they have to have an alternative diagnosis, and they would then select the not sepsis alternative diagnosis. If your doctor is not able to attend to the patient immediately, then they select assessment pending. This does not change any updates. As with all patients, and as we have been doing, the buffalo sticker still needs to be filled in and put in the patient's notes. So, when you suspect sepsis, inform a doctor. Complete your buffalo sepsis sticker within 1 hour of identification. Make sure the bloods are podded. For every hour of delay, mortality from sepsis increases by 7.6%. Go back to your wards, make sure you know where your stickers are. Any questions?